An ounce of prevention is better than a pound of cure. Radio Life welcomes you to the Health Wave, where you can learn with us, meet interesting people, celebrate your health achievements, and find answers to your most bothering questions.
We're still with you. We love being with you. We love coming together and talking to you about your health, about your well-being, and everything that bothers you nowadays. We love doing that and hope that you do too. And really hope that the interest is mutual. And if it's so, if you're with us right now, please share this program. Please let your family and friends join us in this interesting and fascinating, wonderful educational time together. Because here we try to provide you with the most valuable information, with answers to your most bothering questions, with actually even gifts. Speaking of gifts, we're always raffle off something nice to you. And last week we weren't able to do that due to some technical difficulties. Therefore, we decided to raffle off 2 gifts tonight. Just not going far away from that, let's just start and do that. To enter a contest, all you have to do, start commenting. Write something nice to us. Greet us by our page, not the Health Wave, actually we are on Radio Live, so just have to go to the Radio Live page and by the broadcast write something nice to us, or ask a question. We're raffling off 2 things. The one that we couldn't do last time, multifunction eye massager, presented to us by the Kingsway Medi-Spa and Wellness Center in Brooklyn. So find them on Facebook, find their website. Kingsway Medi-Spa and Wellness Center in Brooklyn is giving away this wonderful multifunction eye massager. Start commenting, writing to us if you want to become a winner of this wonderful device. And the other thing that we're raffling off is a cookbook, a very precious, valuable My Recipes cookbook with low-fat dessert recipes, very heart disease friendly and diabetes friendly also. So I really want to know who is going to be the winner of this book. I'll be happy to send it to you. In the meantime, you can just start entering the contest, and I just want to inform my dear audience that this month the Health Wave is celebrating its first birthday, 1 year old, and it's because of you, people who support it, people who watch, and people who truly care about this project. This project is blossoming. Our audience is growing, and we are inspired by that. Keep lining up some very interesting segments. So stay tuned for upcoming calendar, and don't miss our broadcast, because we have some really fascinating topics lined up with very interesting guests. And by the way, you can even become a guest of our program. If you want to be featured in one of our segments, you can do so if you have an interesting recovery story, or you have some special knowledge in the field of health that you can share with us, with our audience. We'll be happy to hear from you. Simply, if you just want to become a sponsor of our program, you always have this opportunity to do. We'd love to hear from you. We'd love to hear from you anyway, because here it's all about you. It's always about you. We want to talk about how to be happy, how to stay and live on this earth for as long as possible, even when, no matter what, even when we have a very difficult diagnosis. Sometimes it's not easy. Sometimes we get struck by something very, very difficult that doesn't allow us to stay happy and healthy and positive, yet we keep going. For example, one such national and even global concern nowadays is visual impairment. believe it or not, visually impaired people are at particularly high risk of degenerative disease or accidents or social withdrawal, depression, and even death. So we may not think so. We may think more about diabetes and heart disease, but problems with eyesight are becoming more and more prevalent in today's world. You know, we learn and interact through our vision, through our senses, like eyesight, like smell, like taste, touch, and hearing. And one of those things is vision that people want to lose, are afraid to lose the most, I would say, and learn from. Most of their information comes through vision, I would say. But not everyone has this joy or privilege to enjoy such a gift, not by choice, but often by neglecting this precious gift that the God gave us. In my hands right now, I have a piece of paper with eye disease statistics from the National Eye Institute. And if you look at this, the numbers go not by hundreds, not by thousands, but by billions and millions. 139 billion people estimated to have problems with vision disorders in the United States, just alone United States. People who have declined vision, 2.9 million, almost 3 million people have that. And this number grows. By the year 2030, 5 million Americans will have declined vision. Very scary numbers. Major eye diseases strike us. Things like glaucoma and cataracts, diabetic retinopathy. It's horrible. Look at the macular degeneration. So those diseases, they go by millions, not by hundreds and thousands. Very scary statistics. So is it time to talk about eye care? Most definitely. Therefore, my special guest tonight in the studio, two wonderful experts, and I would like to ask you to welcome them in the studio. We've got Dr. Grigoriy Solomon with Druid Hills Eye Care, and we have Dr. Arkadiy Yadgarov. Thank you so much for being here tonight. We're welcoming you at the Health Wave. So I'd like to ask you to introduce yourself further to my audience.
Well, Victoria, first of all, we wanted to thank you for allowing us to participate in your show, and wanted to introduce ourselves to your listeners and viewers. My name is Grigoriy Solomon. I am an optometrist. My educational career began in 1993 when I had a chance to enter to Georgia State University. Upon completion of these institutions, I applied and was accepted to the Pennsylvania College of Optometry. As a graduate of Pennsylvania College of Optometry, I'm in private practice for a period of over 16 years. My professional career began in 2004 when I opened my private clinic. Over a period of the last 14 years, our practice grew at exponential rate, and today we're one of the largest privately owned optometric offices in Atlanta. We have 2 full-time practicing physicians, 12 dedicated staff members that are working for us, and I serve as the Chief Operating Officer of this operation. The reason our success was possible is because of the following things we were able to get accomplished. Number 1, we provide good quality care to our patients, which starts with an excellent customer service. Number 2, we operate in a modern, brand new facility which enhances patients' experience. Number 3, we have up-to-date equipment which allows us to provide the level of service we provide. Number 4, we offer a wide variety of services, from comprehensive eye exams to routine eye services to diabetic screenings to glaucoma management to specialty services to emergency service, just to name a few. In our practice, each and every day, not only are we trying to meet patients' expectations, we're trying to beat them and go above and beyond those expectations. Not only are we trying to correct the vision, we're changing people's lives.
Wonderful. Thank you so much. Great introduction. So Dr. Arkadiy Yadgarov, please.
So yes, my name is Arkadiy Yadgarov. I'm an ophthalmologist, a practicing ophthalmologist at Omni Eye Services in Atlanta, Georgia. I've been practicing for about a little over a year and a half now in Atlanta, and I'm trained from New York Eye and Ear Infirmary in a glaucoma specialty, and did residency in New Jersey, but I grew up in Atlanta, Georgia. And I'm actually part of a group practice. I don't have a private practice. We're part of a surgical practice in which we take care of patients that are referred to us that need surgical management.
Mhm. So we have an optometrist and an ophthalmologist. What is the difference between the two fields, or how do they collaborate together? Because many people, let's say, you're told you need to go to an eye doctor. You don't know who to go to, optometrist or ophthalmologist. How do we know?
So optometrists are healthcare providers who are involved in providing primary eye care services. We're trained to manage, treat, and diagnose eye disease. Optometrists involved in determining refractions, and that's why we prescribe glasses and fit patients with contacts. Optometrists are also involved in providing emergency eye care services, and therefore we are licensed to prescribe antibacterial, antiviral, antifungal, corticosteroid medications, both oral and topical. Optometrists are not medical doctors.
Mm-hmm.
And
Yeah, and so to kind of expound on that, ophthalmologists are medical doctors, so we kind of diverge in the fact that there's medical school training, and we do have to go through either a medical or surgical experience prior to going into an ophthalmology residency and then fellowship. Throughout America, you'll find ophthalmologists kind of do different things. There's also the comprehensive ophthalmologist, where they also deal with primary care, similar to an optometrist. But like you talked about, the prevalence of disease is getting greater and greater because as the population ages. And so access to eye care is important. And there are a lot more optometrists than there are ophthalmologists. So we find that in the coming age that optometry and ophthalmology actually end up having to really work together, and the optometrist focusing on their clinical primary care, and that a lot of the ophthalmologists have to then kind of rely on their surgical expertise to kind of start doing more surgeries and alleviating surgical diseases.
So let's say if I have blurred vision, I need to go to an optometrist, correct?
You can go to an eye care professional, an optometrist or an ophthalmologist, anyone that's accessible, that's available close to you, or that's recommendable to you.
And just go from there.
Correct. The importance is an eye care professional, and both optometrists and ophthalmologists are qualified to equally to examine and to diagnose eye diseases.
I see. So who is your primary patient, age-wise, let's say?
In our practice, we see patients from all walks of life. It could be administrative assistants in his or her 50s who has trouble seeing computer screen. It could be a child who walks into our clinic and mother brings them in because they failed the school screening. It could be an older patient who we follow for years and they develop a cataract, and that cataract needs to be monitored and managed. And at this case, we refer them to an ophthalmologist to do the surgery, and that's what we call co-management services. So one thing that I wanted to add, that optometrists are now involved in a lot of co-management, which are non-emergency patients that we send to ophthalmologists and use them as a point of service, and we see them right back to do post-operative services.
Yeah, to actually add on that, so I talked about ophthalmologists kind of doing similar things. I'm actually part of a practice in which we actually do not do primary care. We ophthalmologists actually partner up with optometrists and create a really good mutual kind of understanding that optometrists, they see their patients yearly, and then they really grow their relationships. And when a patient requires surgery, cataract surgery, glaucoma, or whatnot, they can then rely on somebody they know, an ophthalmologist who can surgically take care of the patient, make sure everything goes well, and then brings the patient back to the referring optometrist. So the type of patients I see are actually referrals. I don't see any patients that come straight from the streets. My patients are strictly from optometrists in the area that refer to me for cataract surgery, glaucoma surgery, or other type of ocular surgery, and then are sent back for either post-operative care or after post-operative care for routine management.
I see. So let's say, Dr. Solomon, you see patients that can walk in from the street.
Right. We see patients primarily for their primary problems. So patients who have trouble with the vision, we're their vision and eye care providers. So on one hand, we provide them assuring them that they can see, and we determine their refraction and prescribe them corrective lenses. But on the other hand, we're also involved in providing emergency eye care to them. And when we provide emergency eye care to them, some of those cases required specialty work, and that's where we connected to the ophthalmologist.
So, now I understand better the connection. So what type of diagnosis or eye problems do you see the most, usually, as an optometrist and as an ophthalmologist?
Well, in order for us to talk about diagnosis, I think we need to go through a quick course of optics course, because that would make more sense.
Absolutely, let's go for it.
So, light enters into our visual system through a front part of the eye that we call the cornea. Cornea is a transparent structure. Cornea is like a windshield of the eye. Cornea bends the light slightly, we call it refracting, and after that light goes into the second optical system that we call the lens. Lens usually have biconcave curvature, and a function of the lens is to focus the light further into the retina. Retina is a sensory layer in back of the eye. Retina houses photoreceptors, and the function of those photoreceptors is to take that light energy and through biochemical reaction change it to a neural energy, and that neural energy travels through nerve fiber layer through the optic nerve to our brain, and that's how we see. So in order for vision to take place, both eyes and brain need to communicate. They must work together.
Mm-hmm. Very complicated system.
So system is very complicated, but yet we use it very efficiently. So let's look at it from the way I see it. We can easily see objects far at a distance, up close, and in mid-range, because our lens has a tendency to accommodate.
Mm-hmm.
We can see objects at a nighttime, and we also can see them at a daytime because of two different photoreceptors involved, and we also can see colors.
Mm-hmm.
We have a perception of seeing. We have an ability to have what we call binocular vision, which means we see with both eyes at the same time, and that's why we have a perception of depth, and that's called stereopsis. And that's why it's easy for us to drive a car and be able to judge distances between them.
Mm-hmm.
And our eyes are also working together as a team. So if right eye turns toward the right, then left eye follows. So we don't perceive things double, we perceive them single. So if something is out of focus, out of ordinary, that's what brings the patients in. Mm-hmm. That's our ideal patients. They come with the complaints. It could be a complaint that they have trouble seeing distance objects. It could be trouble seeing street signs. It could be someone has trouble with struggling with the reading, or it could be someone who has trouble seeing both far away and close up, or somebody who has double vision. So this is what brings the patients in. Our most common condition that we see in our office is myopia, or nearsightedness.
Mm-hmm.
In a nearsighted case scenario, light entering into our visual system short focuses. It doesn't quite get to the retina simply because either the eye itself is too long or the cornea is too steep. When light doesn't get quite to the retina, then the image at distance appears very blurry. So we have, anytime we write a prescriptions, any prescriptions have numerical value, so 1, 2, 3, 4, 5, 10. Prescription will have a measurement of the optics, we call it diopter. So a -1 diopter myope, which considered mild myope, would be treatment option for that patient would be just pair of spectacles, and they would do well. We'll be able to see far away distance, and their night driving will be substantially improved. But if it's a severe myope of -10 prescription, then glasses may not be the best option because the cross section of that corrective lens, the lens is too thick. So it's thick on its periphery and it's thinner in its center. So patients experience an optical phenomenon that we call aberrations or distortions. So ideal option for these patients would be to fit them with conventional contacts. Well, contact lens manufacturers gives us a lot of choices nowadays. We have a daily modality product, which is just a single-use lens. We have a monthly modality product, which is monthly disposable or 2 weeks modality. Lenses nowadays are made with good wettability index, so patients who have dry eyes can wear them for a longer period of time. And they have an excellent oxygen transmissibility, so they feel very comfortable.
Mm-hmm.
Second condition that we commonly encounter in our practice is hyperopia. Hyperopia is the exact opposite from myopia. So light entering into our visual system focuses behind the retina, and because either the eye is too short or cornea is too flat. So in either case, complaint of that patient would be most likely seeing up close. But hyperopia is not all that straightforward like myopia. Hyperopes, our eye has an ability to accommodate because our crystalline lens can relax and it can stimulate, so it changes its curvatures, and it can put that light back into the retina. So a lot of hyperopes, especially kids, go undiagnosed around because they can easily offset their hyperopia by squinting.
Mm-hmm.
And this is what's missed most of the time in pediatricians' offices because they can still read the chart, but yet they have undiagnosed condition. So most of the time these kids struggle with reading. Most of the time they have trouble seeing up close, but they are not complaining. Well, it gets even worse if one eye is normal and the other one is hyperopic. So kids perceive this vision as normal. The eye that is hyperopic will eventually stop communicating with the brain, and the eye is going to turn in. And that condition is called amblyopia. So amblyopia is a condition when eyes and brain don't communicate together. A treatment options for amblyopic patients would be, first of all, corrective lenses so they can see and be able to focus and they don't have to over accommodate. They would use corrective lenses to do all the work for them, and we use adhesive patch and patching a good eye, healthy eye, so the eye that is weaker, we essentially forcing that eye to communicate again with the cells in the brain that are responsible for vision.
Wow. So is it done only at your office or somewhere else in America?
No, it's done in most of primary care
Okay.
offices. It's done in ophthalmological offices. Those ophthalmologists who involved in primary care service just like we do are involved in that as well. In our office, with setup we see kids anywhere from age 5 and onward. And that's what we recommend. That's American Ophthalmic Association, in fact, recommends their first eye exam at the age of 5, comprehensive exam. But if child is younger and there's an eye turn, either monocular, which means one eye, or binocular, which means both eyes, then the advice would be to take the child to pediatric ophthalmologist. They have an equipment to diagnose kids at that stage.
May I interrupt you for a second? I have a question. You just said that kids are recommended to have an extensive eye exam at the age of 5, which I didn't know that. I raised 4 children, never knew that. Let's say you take your child to a pediatrician. They check them out and they say everything's fine. Do they still need to come and see you?
So, although vision screenings are offered and it's easier accessible and more cost-saving factor or so, but the screenings are generally performed by technicians, and they're not trained enough to pick up the refractive problems. And generally, screening only involves measuring visual acuity, which means reading chart across the room. Just like I mentioned a second ago, patients who are farsighted, kids, they can easily over-accommodate and see that chart.
Wow.
Now, when they come to our office, comprehensive eye exam consists of, number 1, we check visual acuity, we check color vision, we check stereopsis, which is very important for binocular vision, especially in kids. We check for refraction, we dilate the eye, and we look for signs of pathology. And so one cannot compare comprehensive eye exam with vision screening.
And as far as I know, pathology can go on without being noticed. You may not even know that something's wrong is going on there.
Absolutely. Maybe.
That's right.
Maybe that's the question for you about pathology.
Especially with kids, though, like he says, their brain has just this ability to overcompensate and ignore one eye, and they'll use the other eye. And if it's not caught early with a comprehensive eye exam, and they're too old, sometimes it's irreversible. In other words, it's a permanent amblyopia.
Okay, so kids have what we call critical period. That's when the eyes and the brain communicate, and at that time, the image that the brain receives is supposed to be very clear for the brain to develop properly.
Mm-hmm.
Okay, so if during that critical period amblyopia is caught and a child is put through treatment, the chances of vision recovery is almost 100%. However, if the child comes into us with amblyopia or eye turn after the age of 10, it's very difficult to fix it with the patch. Almost impossible.
So the earlier the better.
Yeah,
Absolutely.
absolutely.
So the surgical option would be the only option for that patient. Now, surgical options will only fix the weak muscle and will align the eyes together so they look straight, but there will not be recoverable vision in the eye. In other words, patients will be able to see, but they still won't be able to see, we call it 20/20 line, which is a standard.
Mm-hmm.
Yep. Yeah. So I mean, along the lines that he said, early screening. United States Task Preventative Force, I think, says between 3 and 5 absolutely needs at least one comprehensive eye exam, and a 5-year-old would fit that recommendation. So anybody who has kids, very important, because like he said, you can reverse blindness. That's what amblyopia is. It's blindness.
Mm-hmm.
So imagine having a kid and catching it early and being able to reverse that versus a 10-year-old bringing it in and going, oh, the kid doesn't see. We didn't realize that. Can we do anything? And then we can't do much.
So we as parents should put it on our to-do list. If we haven't taken our child to an eye care specialist by the age of 5 or at age of 5, right? So we have to do it. My son is 7, so I have to do
You
it
got
as
to
soon
bring
as
him in
possible.
to see this guy.
Mm-hmm. And just to remind you, Dr. Solomon sees patients at the Druid Hills Eye Care. You can call and make an appointment at 404-471-9990. 404-471-9990. Don't wait, just do it. Prevention is the key. Did you say everything that, on that question?
No, I wanted to add a couple of more conditions that we deal with on
Let's
a daily
do.
basis. So the third condition I want to talk about is called astigmatism.
Mm-hmm.
Astigmatism is when cornea, which is the front part of the eye, instead of being equally curved, it's a little bit more elongated. So if the light passes through that cornea, it focuses on 2 focal points instead of 1.
Mm-hmm.
And vision is very distorted. It gets a little bit more complicated because patients could be myopic and still have astigmatism, and it could be hyperopic and have astigmatism at the same time. And finally, the last condition we deal with is presbyopia. Those in the audience who are over 40 years of age probably know what I'm talking about, and that is after a certain time, which happened to be age of 40, the lens inside of the eye loses its elasticity and loses its ability to accommodate, and makes it more and more difficult for us to read. So if all of a sudden you are looking at your computer and you're trying to read what it says in there, you have to push things further away to see better, and eventually you're going to run out of the arm length. A lot of times I hear exactly the same story. People self-medicate themselves. They go to CVS pharmacy and pick out reading glasses, and it's absolutely something I don't recommend
Grow an arm.
because some of these patients, and they don't realize, have probably trouble seeing distance objects. So not only we need to correct their nearsighted problem, we need to make sure we address distance problems. So what are the modalities for this? Well, it depends on their lifestyle. If it's an administrative assistant or an accountant who sees a client, who sees a computer and some kind of reports, then my suggestion would be to put them in multifocal lenses. So those are progressive lenses, which will give them an opportunity to see far away, close up, and everything in between. If it's a computer computer programmer, software engineer who spends in front of a computer all day and generally don't have to see objects at a distance, my suggestions would be to use most likely computer glasses or reading glasses. So it depends on the lifestyle of a patient, so what they really do. We make appropriate recommendations Now, another thing that I kind of specialize in, and that becomes more and more of an interest to our patients, is that I fit patients with multifocal soft conventional contacts, which allow them to see far away and close up and see objects in between. And that seems to be working very well, especially female population is very, very sensitive. They don't want anybody to know that that they have reading glasses, and this modality for them works out very well. And I have quite a lot of patients and quite a lot of success where I take patients completely off the reading glasses, and their ability to perceive everything just absolutely works out amazingly.
So can you explain us a little bit more about it?
Sure. It's an optics in a lens. It's called simultaneous vision design. Essentially, if your pupil diameter is about 3.5 millimeters, then you have a lens that corrects your distance prescription, but right in the middle of the lens you have an elevation zone of about 1.8 millimeters, and that's where your reading area is. So the key to successfully fit that patient is to make sure that lens centers properly. Now, we can adjust an elevation. The higher the elevation, the more the power. So those people who are over 50 most likely need about 2 diopters magnification, a higher add power. Those people who are in their mid-40s probably need about 1.5. Sometimes we can even do one eye, which is a dominant eye. We mostly fit to see distance objects, and then non-dominant eye, we push a little bit more reading so they can have a range far away, close up, and also mid-range, and it works beautifully for patients.
Wow, magic contacts. Interesting. So you're done with the most prevalent diagnosis that you see in your office.
Yes.
Okay.
One of those diagnoses is catching most of my attention, and that's why I'd like to talk a little bit more about it.
Okay. So this is very intriguing.
Yes.
But I'd like to ask Dr. Yadgarov. So who do you see prevalently?
So again, referral center. So mine usually are people who have cataracts and need surgery, or glaucoma and need either medical, laser, or surgical care. In terms of cataracts, remember cataract is the lens inside the eye. Instead of being clear, it starts to get cloudy. Mm-hmm. Everybody gets cataracts. It's something that's just part of aging. And usually after age 60, although it can be earlier if you have diabetes or certain other diseases. And cataract surgery is a way to fix it. It's a curable condition. You go in, you remove the cloudy lens, you put in a crystal clear lens, and nowadays we have technology very similar to what he uses for contact lenses that we put into the eye. And by putting these special lenses inside the eye, we're actually able to get a lot of people off glasses completely.
Well, let me ask you this, sorry for interruption, but many people are afraid of the cataract surgery.
Right. And that fear comes from the fact that, cataract surgery really has changed so much that people don't realize it. 15 years ago, cataract surgery, even 5 years ago, is very different from what it is today. 15 years ago, people used to have to be in the hospital to get cataract surgery. 10 years ago, people used to have complications where the cornea gets decompensated. But every few years, there's been leaps forward. And nowadays, the complication rate is extremely low. It has one of the safest adverse effect profiles of any surgery done in America. In other words, out of all the surgeries done, cataracts is one of the safest in terms of complication rate and just how many surgeries are done. It's one of the most commonly surgeries performed, and it's quite much safer. So in terms of people saying how risky it is, it definitely has risk, but it's a lot safer than what it used to be.
So can you say that generally speaking, cataract surgery can be considered a safe surgery?
I never say 100%, but I say 99% of the time, usually people have good outcomes. Even if it requires additional medicines to get you there, yes. Mm-hmm. I think in terms of devastating complications, those are less than 1 in 10,000 cases, so very uncommon.
I might add to that.
Please.
I've been doing it for 16 long years, and I have never seen a single cataract complications yet on any of our patients that are referred to an ophthalmologist. Wow. So the skill that these guys have is just absolutely outstanding.
That's good to know.
Yeah.
That's very reassuring.
It is. It's a much safer surgery.
It's a sutureless procedure. It's called clear cornea.
Yep.
I mean, he can probably go over more than...
Right. And nowadays you'll see bladeless because now we use laser technology to make cuts. So now you have a very much more precise surgery done. And like I said, specialty lenses. We use all types of kind of devices to help with the surgery. In fact, Omni Eye Services, which is where I work, we're the only center in Atlanta that uses dropless cataract surgery. So that means you don't have to use any drops even after cataract surgery. So it's come a long way, and it's a very advanced surgery.
And you said you also see people who have glaucoma a lot.
Yes. So glaucoma is a completely different, ball game.
It's a complicated thing, isn't it?
Well, it's pretty much the hypertension of the eye. What that means is that the pressures inside the eye, instead of being in the normal range, they start going up. And when they go up, they damage the nerve of the eye. And the nerve, like Dr. Solomon said, really is what connects the eye to your brain. It's the cable connection, the optic nerve. And glaucoma is a disease of the cable connection of your eye. And so the worse the glaucoma, the worse that connection is, and eventually leads to darkness, difficulty at night, peripheral vision problems, and eventually in the late stages, blindness. And unfortunately, this is really one of those conditions that the brain ignores. People can have mild, moderate, to even severe stage glaucoma, and when I tell them that they have glaucoma, they go, but everything's fine. And it's really one of those diseases that can be extremely hard to treat and manage because the patient doesn't realize what's going on. So early prevention is the key. Going into seeing your eye doctor, having them catch it early before we have to deal with all the complications and risks.
So what causes it?
It's a problem with drainage in the eye. There's no actual pinpointed reason why the drain stops working. A lot of times it's hereditary. So if your father or mother had it, or your grandparents had it, or siblings, it's a higher prevalence. But overall, we don't know why certain people get it, the primary kind of glaucoma. And that's why it's so important that you don't, just because no one in your family's got it doesn't mean you don't need to get tested. And then there's also secondary causes of glaucoma, such as diabetic-related changes, inflammatory changes. There's all kinds of secondary causes, but all of it leads to high pressures, and the high pressures cause damage.
So, Dr. Solomon, if you get a patient, if you see someone is developing glaucoma, you refer them to a specialist?
Okay, so in our office, when patients come in for a comprehensive eye exam, one of the part of this exam is to measure their intraocular pressure. So when we measure intraocular pressure, and if pressure seems high, we ask patients about family history of glaucoma. We're trying to get as many risk factors as we can possibly find. So glaucoma is nothing more than disease of risk factors. Family history of any diabetic status in someone's health, hypertensive status, things of that nature. And the only one risk factor that can really control is the pressure. So if the optic nerve looks bigger than normal, if the pressure looks higher than normal, generally in our office, in our primary care setting, we have a technology where we perform visual field tests because because glaucoma is a disease that eventually will affect your peripheral vision. So we have a visual mapping equipment that allows us to see what their visual mapping is. If the glaucoma is mild and the glaucoma is diagnosed, generally mild case of glaucoma, we are treated in the office with the use of therapeutic drugs, and we follow them every 6 months or every year just to be sure that the visual field is staying normal and there's no further damage. However, there are some patients who had glaucoma for a while, and those glaucoma more advanced. This is out of primary care setting. This is something that Dr. Yadgarov needs to take care of. So this would be perfect referral.
And how do you take care of it?
So, yeah, and unfortunately, studies show certain people do great with drops, and that's where the primary care doctor starts the drops and monitors, and the eye drops lower the pressure in the eye, and then they do great. But unfortunately, some people, you put the drops, and their pressures are either don't drop enough or don't drop at all, and you'll see that they might start getting a little worse. The nerve, when they monitor it with all these tests, shows a little bit of worsening, and that's really when we start getting involved with lasers. We do a procedure called SLT. SLT is about a 2-minute procedure done in the office. It doesn't hurt, and it applies a warm beam of energy into the drain of the eye. And when that drain absorbs the warmth, it dilates, opens up, and the fluid pressure goes down. Okay, and so that's a really good treatment I provide for all my patients. The effect lasts for about 3 years and can be repeated. And so that's one way we treat it. The second way we treat it was surgery. Nowadays we have minimally invasive glaucoma surgeries. 10 years ago we used to do these kind of bigger surgeries where we put big drains in the eye. Really in the past 5 years now, we've come up with these really finesse micro-invasive glaucoma surgeries that I offer to my patients before we go on to the big surgeries. And these micro-invasive surgeries are very safe. They have better tolerability, and they're able to usually control the pressure in the majority of people fairly well.
I also know lots of people who have glaucoma and are referred for a surgery, but they're afraid.
So afraid. And that fear comes from the fact that the usual surgeries we did for glaucoma, one of them is a tube that we put in the eye, and the one is a filter that we put in the eye. And both of those have high complication rates. And that's where the fear comes from. A lot of people will say, my cousin had glaucoma surgery and they almost went blind. And, unfortunately, that's just what we're dealing with. Some glaucoma, advanced glaucomas, you try to do whatever you can, including these high-risk surgeries. And like I said now, in the past 5 years, even the past 1 year, there are a handful now of micro-invasive, low-risk glaucoma surgeries that we can do. And patients do very good with very low risk.
So I want to know, in your opinions, can glaucoma be helped with clean diet? Many people want to know that.
So can it be helped? No studies show that it can help. But there is studies that shows that people who have a higher intake of omega-3 diet have a decreased prevalence of glaucoma. And it's just a correlation. So nothing that's been proven. But if there's something you could do, absolutely. Increase your omega-3s, nuts, fish oils, salmon. That would definitely help in some way.
Well, I wanted to share also, I have clients, nutrition clients who have glaucoma, and definitely I've seen over the years people who have been eating plants that have omega-3s, like leafy greens and stuff, definitely have improvement in their glaucoma rates.
Okay. And I will say leafy greens and, carrots and these beta-carotene rich supplements, maybe not so much for glaucoma, but definitely help the retina. The retina is where the photoreceptors, the rods and cones, and those use a lot of those same kind of proteins like beta-carotene. So absolutely, green leafy vegetables, carrots, tomatoes, this actually helps the retina, and in theory should help the retina survive longer and have possibly less degeneration.
Great. Well, I'm still intrigued by the diagnosis that Dr. Solomon didn't reveal to us. Would you please talk about it now?
Absolutely. That diagnosis is myopia. I revealed it, but I revealed it briefly, but I want to talk a little bit more about it.
Please.
Because myopia can lead to some serious consequences. And partly we already covered it. But anyway, the incidence and prevalence of myopia is increasing in the world. In 1970s, 25% of adult population in the U.S. Was diagnosed as myopia. In 2004, the same study was repeated in 45% of the United States population is now myopic, and in Asia, it's close to 85%. So there's certainly some genetic predispositions to it, because if your mom and dad are nearsighted, then chances are the child is going to be nearsighted. But there's also environmental components. So we now live in a digital age. Excessive overuse of computers, especially in a young age, causing over accommodation and over focusing, which forces the eye to grow. And when the eye grows, myopia grows, and nearsightedness gets higher and higher. So
myopia means nearsightedness.
Correct. Myopia means nearsightedness. So nearsightedness can be divided by 3 subcategories. One of them, so it's a mild, moderate, and severe. So mild myopia, conventional glasses would be an ideal option. So for moderate or severe myopia, then just like I said, those patients can have some serious complications in their life. So let's just think about it logically. So as the eyeball keeps on growing and the retina gets thinner and thinner and thinner and thinner, essentially at some point in time, the retina is going to get so thin it can rupture. It's called retinal detachment. Patients who are myopic also show early signs of glaucoma, we just talked about it, or more chances of developing, more higher risk of developing glaucoma, and early formation of cataracts. So maybe you can go a little bit more in details about latest and greatest.
Yeah.
about cataract treatments? And
Right. So, nearsighted people absolutely need to be. One thing they need to understand is, they really have to be married to an eye doctor. Okay. People who are nearsighted have a much higher risk of complications, especially retinal detachments and retinal tears. And a lot of times you don't even know you have it. And so when they do a dilated eye exam, he's able to catch a lot of that. And like he was saying, a lot of co-complications, sometimes early cataracts, sometimes even glaucoma can coincide and be hard to diagnose. In general, a nearsighted person, though, can be managed properly. We can take care of the cataracts. We talked about all the lens type of situations we can do. We can give, a lot of times people who have these thick glasses, after cataract surgery don't need any prescription at all, which is kind of a nice thing. But, I will say it's extremely important in terms of prevention. Go see your eye doctor, and, Dr. Solomon also deals even with kids with nearsightedness and prevention of worsening of that nearsightedness.
So when do you see nearsightedness more, in children or in adults?
So I'll answer that.
Yeah.
So nearsightedness in kids needs to be particularly taken care of, because the eye growth, we call it axial elongation. So normal axial length of the eye is about 22 millimeters. So the distance from the cornea to the back of the eye, the retina, is about 22 millimeters. If the distance of the eye grow because the body grows, then the axial elongation causing spike in myopia. And that's what we see in kids, because kids come to us at the age of 5 and we follow them. And sometimes somewhere around the age of 10, that's where we start seeing symptoms of nearsightedness, and we're very cautious. So our first initial approach for nearsighted management is to prescribe them mild glasses and bring them back in 6 months on the end to recheck their refraction. If the refraction is showing a sign that it's stronger, and depends how much, if it's a diopter growth a year, then we would look at the alternative options to slow down myopia, and glasses would not be an option. So one of the things that I do, and I'm involved in my practice, I am an orthokeratology specialist, and orthokeratology so far has been an answer to myopia growth.
What is orthokeratology?
Okay, so orthokeratology is a non-surgical eye treatment where we use specifically designed rigid gas perm contact lens that we insert in patients insert in their eyes while they sleep. So the treatment of the eye happens during sleeping cycle. In the morning, patient removes the lens and maintains clear, natural vision throughout the day. Now, the mold need to be worn every single night for the cornea to be molded. And that particular treatment shows not only correction for myopia, but also myopia control. So how does it work? So internal fluid forces in the eye that we are able to catch with this reversibly designed lens helps us to reshape corneal epithelium. So essentially we take in a force of a lens and putting a dent, or we call it ablate, the central part of the eye. So we push it down and we elevate mid-periphery of the eye. So by pushing down the cornea or flattening it, we offset myopia, which means patients are completely normal after wearing the lens. They can see perfectly distance and near, but the elevation in mid-periphery allows for defocus. So remember what I mentioned in the beginning. So over use of medical devices causing over accommodation and over focusing. So if he somehow can decrease that over focusing, then myopia will be controlled, and orthokeratology is the answer. Now, how do we know that? Study. Myopia controlled study concluded that if patient is diagnosed with nearsightedness and their nearsightedness is not more than 4.25 diopters, there's 63% chance of nearsightedness to slow down or to stop from growing if they're introduced into ortho-K lens. I'm going to give you a real example. 9-year-old patient comes into my office with her mother. Mother is concerned because she took her to several different doctors and everybody just prescribed her stronger glasses. When I saw the patient, her prescription was about negative 275. A 9-year-old patient with 275 prescription, I just wanted to prescribe her basic conventional glasses so to improve her vision and see her in about 6 months. And that's exactly what I did. In 6 or 7 months, she comes back to us, and her prescription jumps from 275 to 4. There's a huge growth, and she's only 10 years old, or 9.5 at that time. So at that time, I decided to, I talked to mother, we through lengthy discussions, we finally concluded we wanted to try an ortho-K lens. So in our office, we have a specific equipment that allows us to measure the corneal curvature, and we can design the lens. We have an instrument called corneal topography, which allows us to measure curvature of the lenses. And we designed the lens based on that. And when the lens arrived to the office, she came in for a fitting. We fitted that lens. It generally takes about 2 full weeks for complete molding, which means 2 full weeks to completely flatten her cornea so that her nearsighted state will be pretty much 0. So essentially, Mom was excited because her child, for the first time, could see a chart, and not the big letter E, which is usually a big letter on our chart, but the small, tiny letters. The standard of care that we have is to see 20/20 line. So a child sees 20/20 line in each eye separately, and binocular, which means together she can see 20/15, even line better. So a year and a half down the road, they were just here in my office a couple of weeks ago. They came back, and there was a yearly renewal for their lenses. I insisted to unmold her. Unmolding means stop wearing the lenses, so the cornea can grow back to its original shape. I am not a research institution. I'm a private practice. All I wanted to do is see if the research studies is valid. So I molded her back and brought her back in a week, and I measured her refraction. Her refraction was exactly -4. It was mind blowing.
Wow.
And it's Mom is excited because for the first time I could offer her an alternative treatment, which slows down, clearly shows the sign of slowing down myopia. And again, I only give 63% chance, whatever study does. So if myopia creeps up a little bit, that's fine. The idea is to make sure that this patient don't get severely myopic. So prescription of -8, -9, -10, -11 will have some devastating consequences. So who are candidates for this particular product? Well, kids, of course, because we kind of killing two birds in one stone. First of all, we offset their nearsightedness, allowing them to see, and second of all, we're controlling myopia. Aside just from correcting myopia, imagine what child is experiencing. Their self-esteem is much better. The ability to play sports, feel about themselves. They feel great. They can see everything. They don't need to use any glasses. So they can use sunglasses which don't have any thick lenses and prescriptions. So that's very exciting. So sometimes we recommend ortho care for adults. Who would be a good candidate? Well, patients who are working in an environment where there's a lot of dusty environment, like construction workers, for example, who can't wear conventional lenses or glasses are perhaps too thick. Patients who are, for example, firefighters, they're in a dangerous situation. They can't have a flimsy, soft lens. It's not practical. Patients who are in wrestling, they like to have ability to see. Sometimes even pilots, believe it or not, come to us because they want ortho-K. In fact, I might add, LASIK procedure, which is a corrective corneal procedure using laser, was not permitted by the Federal Aviation up until I think 7 years ago. So a lot of these patients were coming to us to get ortho-K lenses. So now LASIK is finally approved by that, approved by FAA. So those pilots obviously want to get LASIK done. But I just want to mention it just to see how popular that is. Now, one thing that I do want to add, Federal FDA, Federal Drug Administration, gave a clear seal of approval to us in 2002 that orthokeratology is a relatively safe procedure, and the risks that are associated with it are not more than risk than just basic conventional contacts.
How popular is it?
It's not very popular, and I might add that not all optometrists are orthokeratologists. I got interested in that probably about 4 years ago. It requires specific equipment. It requires much more continuing education classes. I had to travel to all these conferences in a skill. But it's getting more and more popular, and I have quite a few patients in it. And again, from myopia control standpoint of view, this is the only really viable options we have. There is another more like anecdotal treatment where we use drops that relax the accommodation. Those drops called atropine, but it's in a low dose, but sometimes it dilates the eyes, and that means that kids need to have 2 pair of glasses, one for distance, one for reading. and parents don't like medicate their kids. So
Of course.
orthokeratology
Is the answer.
is the answer. But here's what's interesting. Sometimes it's interesting that a kid's cornea is so moldable. It almost happens within 20 minutes. So sometimes I bring parents in, and just to impress them, I measure the curvatures of their corneas of the kids and calculate the lens. And in the office, I have a bunch of trials which I can put in the patient. So if they're about -1.25 or -2 or -3 even sometimes, I just put the lens on and ask a child to close their eyes, and I'll just say, I'm going to come back, and I'll come back in 20 minutes. We take the lens out, and their vision improves on my chart almost 5 or 6 lines.
Wow, that's very impressive. Yeah. We have so many questions to you, doctors, but I do have questions, and I know.
I just want to add one thing, though, that a recent study showed that if your kids are outdoors more than indoors, also lesser chance of getting myopia. There's a big Taiwanese study that showed. So,
Wow.
make sure your kids spend a little more more time outdoors compared to indoors, and then, also consider ortho-K like he talked about.
Can I add to that one?
Please.
To that study? Okay, so that's exactly correct. When kids are outside, play outside, they are staying away from our computer, from electronic devices, number one. Number two, they get vitamin D.
Sure.
Vitamin D shows the signs of slowing down myopia. It's just an add to that.
Very interesting. But I want to know, many people who have declined vision want to believe that they can do something naturally by doing some eye exercises and eating well, hoping that their vision can be improved. How true is that from your standpoint?
I'll answer that.
Please.
So there's not real studies that available to patients if you have healthy diet that would improve your myopia or hyperopia. So that doesn't stand any ground. However, it will improve your vision indirectly, meaning that if you maintain a healthy lifestyle, meaning eating plant-based food, incorporate omega-3 fatty acids in your diet, your overall health and risk factors for diabetes or hypertension, arthrosclerosis would decrease, and that indirectly impacts your vision.
Of course.
Now, is that going to fix your myopia or hyperopia? Highly unlikely.
If you already have it.
If you already have it, that's exactly correct. Now, there is a discipline in optometry that's called they're optometrists who are binocular vision specialists, and all they do is vision therapy, and that's a specialty which I sometimes refer patients to, and those practitioners generally use eye exercises to improve someone's sight. In my opinion, generally patients who are referred to binocular vision specialists are kids or sometimes even adults who have trouble with binocularity, which means double vision, possibly amblyopia. I just talked about it, when eyes don't communicate with the brain. So they have vision exercises to improve the eye's ability to accommodate and be able to read certain signs. So from standpoint of view of exercising,
for certain conditions.
From standpoint of exercising, the vision therapy does help patients with vision. What vision therapy will not do is reverse nearsightedness.
Yeah, I mean, there's nothing that shows, at least study-wise, that eating something or doing all these kind of eye exercises will reverse a condition. But it doesn't hurt to eat healthy. It doesn't hurt to exercise. I think it only helps. And in terms of these kind of unique type of exercises for the eyes, I'd refer them to a vision therapist if they're that interested in it. But again, from what I understand, vision therapy is better for people who have double vision or an actual condition.
Very interesting. We don't have much time left, unfortunately, although we could probably talk more for another 3 hours or so. But I think there's the time came for us to draw our presents. Do we have any comments or questions?
Just comments, no questions.
Okay, so comments. So we do have people who want these gifts. Let's do that. I would like to offer to our guests to draw a number, and we'll see who's going to be a winner for this multifunction eye massager? First.
L.
Not L. Turn it upside down. It's number seven. It's
Oh,
numbers.
sorry,
It's not letters.
7. Okay, gotcha.
So number 7. Is there a number 7? Who is the winner?
Natalia Nishkina.
Natalia Anashkina. Natalia, congratulations, you are the winner. Natalia is our, watches us regularly and supports our program, for what I really, really appreciate you and applaud you. Thank you so much. I'm glad to send this gift to you. You will enjoy this multifunction eye massager. And the second winner is going to be number 6.
Alla Kozlova.
Alla Kozlova, the person who wins the most gifts during the Health Wave show. Alla Kozlova, you get another copy. I think you already got one of Dessertless Cookbook. You can give it away. You can give it as a gift to your family member or to any friend that you have. Congratulations, you're going to get this gift in the mail from me personally. I'll be more than happy to do that for you. That part is always fun and nice, to do the raffle off. But because our program is coming to an end, dear doctors, thank you for being here tonight. And I wanted to ask you to say a few more words of your words of wisdom to our audience.
I actually have very important words of wisdom to portray. A lot of times people come in and they don't realize there's something wrong with one eye because the other eye compensates. Everybody who's listening, cover one eye, look around, now cover the other eye. And that's important because that's usually when people realize that one eye is not as good as the other. And that's kind of a good screening way to figure out if there's anything wrong. So
that means you need to go to
needs to go to an eye doctor. Exactly. But in general, everybody should get an eye exam every 1 to 2 years. Okay, so it's very important.
Thank you so much.
I think one of the reasons to come and see us because we can better understand your vision and eye health that fits your lifestyle. We believe that education has an important role in your overall health and wellness. We believe prevention has an important role in your wellness. And after all, you only have 2 sets of eyes, and we just want to make sure you know how to care for them.
The precious gift from the God.
That's right.
Absolutely. And I just wanted to add to this, thank you so much for being here with us. Thank you for sharing this program. We also believe in education and prevention. That's why we provide you with the most valuable information we can during our programs. Stay with us, stay on the wave of health, and we'll see you next Thursday. Be well. Good night.
When health is absent, wisdom cannot reveal itself, art cannot manifest, strength cannot fight, wealth becomes useless, and intelligence cannot be applied. Radio Life presents the Health Wave, maximum information for making wise health and lifestyle decisions.